therapies developed by physicians and therapists that's focused on returning people to their previous level of function. So this kind of care is mostly needed after a problem has already occurred and it has already affected someone's functional ability. An example of this could be like a stroke or a fracture or some period of immobility. And then restorative care is more of a care that helps individuals maintain their current level of function, improve their functional ability, prevent decline and complications, and promote the highest quality of life. And this kind of care is more often offered by nurses, and you don't really need a medical order for it, and it can occur in any setting. And this can be appropriate for every older adult. So rehabilitative care is more trying to fix a problem and get someone back to what they used to be, whereas restorative care is more just trying to improve their current level of function. And then this chapter also talked about sarcopenia. I know we talked about this in class 2 previously. And this is the age-related changes to the skeletal muscle tissues, and it results in a loss of muscle mass. Some of the risk factors for sarcopenia include immobility, poor blood flow, increased inflammatory cytokines, oxygen radicals, a decline in anabolic hormones, malnutrition, and reduced neurological drive. So there's this cycle between sarcopenia and frailty. They kind of just, sarcopenia can lead to frailty and frailty can lead to sarcopenia. And they're kind of hard to tell the difference because they have a lot of things in common. So frailty is a pretty big concern because it can lead to falls in the elderly population especially. It can also lead to disability, increased rates of hospitalization, admission, and death. And like I said, it's a cycle, one leads to the other, and it's really important that these conditions are recognized early and that interventions are implemented as appropriate. And then this picture just shows, on the left is a normal muscle, and then on the right you can see the reduced muscle mass in sarcopenia. And then we have different terminology to describe functional status, and we have talked about some of these terms before in nursing school as well. But just to go over them, the first term is disability, and this is the inability to perform an activity in a normal manner. So an example of disability could be someone having arthritis and not being able to cut their food as a result of having that condition. And then we also have frailty, like I was just talking about. This is the weight loss, slow walking speed, low grip strength, low activity levels. And an example of this could be someone having weakness in their legs and then them suffering falls as a result of that weakness. And then we also have impairment, which can be psychological, physiological, anatomical loss, or abnormality. And then an example of an impairment could be someone having an amputation. So they'd have a physical, anatomical loss of their limb in that case. And then we also have handicap, which is a limitation in ability to fulfill a role. So kind of going off of the last one, if someone had an amputation, an example of a handicap would be them no longer able to perform their job duties and them losing their job as a result of their amputation. And then all of these terms are used interchangeably, but there are slight differences between each of them. So disability can come on suddenly, or it can be more of a chronic, gradual situation. Most people generally are not prepared for a disability to happen to them, and it can lead to many disruptions in their life. And attitude and coping capacity play a huge role in how disability affects a person's life. So whether people have a positive or negative outlook on life prior to their disability can actually affect how they're going to handle their disability too. And family members of people with disabilities can also play a huge role. Some family members might try to take over the role and do everything for their loved one, and this can be good to an extent, but then that person might start to lose their independence, and they can start to lose some of their functional capacity as well if they're not using certain muscle groups or doing certain things for themselves. So it's better for the family to help as they can, but also advocate for independence for their loved one. And then disability can also cause different losses for the person, including a loss of function, a loss of their role, a loss of income, loss of their status, loss of independence, and even loss of a body part. So these patients may also end up going through stages of grief as a result of their losses. And then we also have 3 principles of rehabilitative nursing. They include increasing self-care capacity, eliminating or minimizing self-care limitations, and acting for or doing for when the person is unable to take action for themselves. So for the first one, increasing self-care capacity, that means just to increase the ability for the patient to care for themselves. And a nurse could help with this by encouraging the patient to perform arm exercises to build their muscles so that they can better move around. And then they also, for the second one, this means just to minimize any issues that might get in the way. So a nurse could help with this by, if a patient's in a wheelchair, they could advocate for wheelchair ramps to be implemented around the area so that these people are moving around without any limitations to where they can travel to. And then for the third one, this means that the nurse can assist the patient with things that they're not able to do themselves. So if a patient is having trouble moving their extremities, the nurse could help to assist with passive range of motion instead of active if the patient can't do it. So this would help for the patient to stay mobile and exercise their extremities. Nurses also should be following certain guidelines when working with these patients. They should really be assessing their patients and knowing the strengths and weaknesses of their patients, and they should provide adequate time for working with these people because things might take a little longer. And they really need to stress the patient's accomplishments, because something that might seem like a really small accomplishment could be a huge accomplishment for the patient. And then they just need to be on the lookout for any kind of risk factors that could worsen a disability or impairment. And then just demonstrating hope and optimism can go a long way as well. And the last piece is that this is a really individualized process that can be different for every single patient. So it's just important to do ongoing reevaluation and recognize that changes may need to be made throughout the process.
So difficulties with activities of daily living and instrumental activities of daily living often correspond to how much help, supervision, and hands-on care an older person needs. This can determine the cost of care at a facility, whether someone can be considered safe to be living by themselves, or even whether a person is even eligible for certain long-term care services. Can trigger medical evaluations that may uncover medical issue. So it's important to understand the root cause of the problem or understand why there's a change in ability. So skills or activities of daily living are basic tasks that a person needs to be able to live on their own independently. Health issues and aging may make it difficult for seniors to complete everyday tasks that are essential to keep them healthy and safe. And examples of these are eating, washing, dressing, toileting, or even just moving and walking. And instrumental activities of daily living are more complex activities required for independent living that involve thinking and organizational skills. So some of these are preparation of meals, managing finances, using a telephone, and safe use of medications. So it's important to assess their functionality. You can do this by even just asking the patient if they've noticed changes. You can also ask loved ones if they've noticed anything that's concerning. And of course, it's just always important to be patient because better at certain times of the day, such as in the morning. from page 460 in the book, and I just wanted to include this to show the different levels of independence. So there's total independence, partial independence, and dependence, and I thought eating would be a good example because we've all seen that from Knox. So we all probably at this point have fed a patient here, and also notice patients that need like their orange juice and things open to them, and then some can handle everything on their own. Like, there's static. Positioning a patient in bed is important for maintaining alignment and for preventing pressure ulcers, foot drop, and contractures. Proper positioning is also vital for providing comfort for patients who are bedridden or who have decreased motility. When positioning a patient in bed, supportive devices such as pillows, rolls, or blankets can be used, along with repositioning, and it can aid in providing comfort and safety. So correct body alignment provides optimal respiration, circulation, and comfort, and it can prevent things like contractures and pressure ulcers. Always make sure to avoid friction and shearing, especially in the older population. They have very fragile skin sometimes, and always get help and use proper body mechanics. So range of motion is how well someone can move the joints in their body. Many people lose range of motion as they get older. Some reasons for this could be tight muscles, injury, pain, arthritis, or just lack of activity as well. Often older adults do not know how much range of motion they've lost until it's hard to do things like walk, shower, get dressed, or cook. Less range of motion makes it more difficult, makes it more likely that a person could fall. The best way to protect range of motion is to just keep moving. I like the term motion is lotion. Benefits are promotion of joint motion, muscle strength, it stimulates circulation, you can maintain the functional capacity and prevent contractures. So patients should be encouraged to put all their joints through full range of motion at least once a day. It becomes especially important as they age to incorporate these into their into normal fitness routines that are intended to support and maintain a healthy range of motion. Doing so supports long-term independence and increases coordination, and it can help joint stiffness. While offering assistance with range of motion, you should make sure to always support above and below the joint being exercised. Make sure to move it slowly and smoothly. You can repeat this movement 3 times. It's really important. Do not force the joint past the point of resistance or pain. And as always, document. When rehabbing patients, watch out for these warning signs. It could be a sign to discontinue or that they're not tolerating it that well. So this is an example from the book. It's on page 462, and it just shows what the normal range is for all the different joints. This is something that you might see in a rehab or clinical setting, and you can keep track of the patient's range of motion to see if it's decreasing or it's getting better. If you're confused or like me, I need a refresher on some of the terms. So that's there's a good box on page here, but it's box 32-1 that goes over all the motions.
Okay, so now we're going to be talking about mobility aids. Mobility aids can enable patients to independently fulfill their universal needs and enhance functional capacity. If misused, however, these aids can present significantly safety risks. As we can see in John Knox at clinicals, a lot of people do use mobility aids. Wheelchair, canes, and walkers are some of the examples that is included in this chapter, and they can make a difference between older person living full lives or being confined to their immediate environments. The first principle in using a mobility aid is to use them when necessary. Using a mobility aid because it's quicker or easier can result in unnecessary dependency and decline of functional capacity. When using a mobility aid, instruction should be provided because inappropriately used canes, walkers, or wheelchairs can subject the older adult to falls or other injuries. So the first the first one that we're going to be talking about is canes. So depending on the disability, various canes may be recommended. Canes should be should be individually fitted, usually based on the distance from the greater trochanter, usually about a 6 inch, from the side of the person's foot. The cane should be used on the unaffected side of the body and is advanced when the affected limb advances. For example, if the right leg is affected, the person holds the cane in his or her left hand and advances it with the advance of the right leg. So these are the different types of canes. So the first type is just a standard grip, and the second type has a wider base and has 4 points. The third type has a larger base, and it has also a quad cane. The fourth type is a small based, more circular, and it also has a quad cane base. Walkers. So walkers, a variety of walkers can provide support and stability. Walkers are sized by the measurement from the patient's trochanter to the floor. As you can see on the top right, how to use a walker when walking, it should be the person should place his or her hands on the sides of the walker with the elbows slightly flexed. During ambulation, the person advances the walker, then steps forward. Appropriate use should be followed during transfer activities also. And as you can see a picture on the bottom right, when lowering to a seat, the person should back the walker to the seat. When lifting from the seat, the person's hands should be on the arms of the chair. The person should push on the arms of the chair to a standing position. The person should not use the walker to pull himself or herself up to a standing position. Wheelchairs. Wheelchairs should be individually fitted. The seat should be slightly larger than the person's width to prevent pressure and friction. The person's arms should be able to reach the wheels easily, and footrest should be adjusted to support the patient's foot in a flat position. Wheelchairs should be checked routinely for ease of wheeling, like the function of brakes or if there's missing or broken hardware. These aids can help individuals with independent ambulation, and also there's also assistive technology that can promote other aspects of independent function. These can include Velcro attachments, computer, voice synthesizers, remote control devices, and robotic arms.
Yeah, teaching about bowel and bladder training. Educating older adults with incontinence about bowel and bladder training can help them improve continence. However, the nurse must evaluate the physical and mental capacity of the patient to achieve continence before a training program is begun. Some patients may not have the functional capacity to control their elimination despite good intentions. To initiate a training program with them would be unrealistic and frustrating. If the patient has the capacity to be continent, training should begin as early as possible. Continency is a crucial factor in training programs. The gain of the day shift in keeping the patient continent are lost if the evening and night shift do not toilet the patient at appropriate interval. Next slide. Promoting physical, maintaining and promoting mental function. So promoting physical functioning is only one aspect of rehabilitation. Equally important are efforts to restore, maintain, and promote mental function. In institutional settings where the contact patients have with staff mainly resolve around illnesses and related issues, or in their own homes where they may be socially isolated, healthy mental stimulation may be sorely lacking like any other function. Mental function can deteriorate if exercised. Thus, all rehabilitative efforts include the promotion of mental activity. Mental stimulation is a highly individualized process based on the unique intellectual and educational level of the patient. Some people enjoy reading the classics, others are barely interested in reading the local newspaper. Some people thrive on large social events, whereas others could spend days alone solving a crossword puzzle. Some people maintain a large network of contact through social media, though others are challenged using the phone. Next slide. Reminiscences and reality orientation. Reminiscence is one mental stimulating activity that has a therapeutic aim, and studies have showed the value of this process as a means of improving memory, validating existence, resolving past conflict, and enhancing quality of life. Reminiscing, including playing old records and ask participants what their lives were like when those records were popular, showing old photographs and asking participants what memories arise and asking them to describe the important pieces of history they have witnessed. Perhaps most important skills of nursing to use in reminiscence activities is listening. Reality orientation. Patients with moderate to severe memory loss, confusion, or disorientation require therapeutic effort to keep them mentally integrated with the world around them. For these patients, reality orientation is effective tool, more than just a simple review of the date, weather, next meal, and next holiday. Reality orientation is total approach to keeping the patient oriented. Clock, calendars, holidays, team decoration, and reality board enhance but do not substitute for staff interaction. Consistency is crucial to promote orientation. Next slide. Community resources. Every community has its unique resources for persons with rehabilitative needs. Such resources provide education support and various forms of assistance to the disabled and their caregivers. Social workers, physical therapists, occupational therapists, speech and hearing therapists, and rehabilitation and vocational counselors are among the professionals who can offer guidance in locating appropriate resources. Local libraries, health departments, and information and referral services for older people can also provide valuable assistance.
The case study that we have, I was very fortunate to find this case and be assigned and be able to work with her. I think the highlight of it is that she was 81 years old. She's an 81-year-old Hispanic female that was admitted to rehab. She was 2 days post-op, and that was 5 weeks ago. So it was really, she was getting ready for discharge. She had a comminuted fracture of her patella, of her right patella, and I showed a picture of it on the slide so we can all be reminded what a comminuted fracture is. And what they did was an ORIF, which is an open reduction internal fixation for the comminuted fracture. What happened was she fell in a parking lot and she tripped over a car stop. And when she tripped over the car stop, she went into a car that was there with her shoulder, thus fracturing her left humerus. And then she went down on her knee, fracturing the right knee. So that's how the injury occurred. And I think it's important to know that in any case history so that we can also assess for any other injuries. Fortunately, she had no others, which is amazing too at her age and considering her bone structure that those were the only two injuries. The left humerus was a simple fracture. It was non-displaced. Next slide. Also, her past medical history, I think for her age, is very representative, if not better than a lot of people at her age. She had hypertension. She had a history of colon CA. She has diabetes type 2. She has hyperlipidemia type 2. Just to remind you that it's familial hypercholesterolemia, and her increase was in LDLs. She had CAD, which is typical of that age group, coronary artery disease, hypothyroidism, again, things that we've studied that typically occurs in this age group. She had GERD, gastroesophageal reflux disorder, and also she had a history of, and also some depression, but she had a history of major depressive disorder and general anxiety disorder. Next slide. Vital signs, she was, again, very pleasant, very cooperative. She was lying comfortably in bed reading, didn't show any signs of distress. And again, for her age, I mean, without the medications, I think that could be a problem, but the medications So this shows another good example of just the restorative ability and the way that, first of all, the physical problem was resolved, plus her medical regimen was keeping her at a blood pressure of 119 over 62, which is better than mine. Her pulse was 79, respirations were 18. Even her weight wasn't too bad. She was at 159 pounds. Her O2 was 95 on room air. Temp was 97.3. When I asked her about pain, she said she had zero pain level, which too is fabulous considering the 2 injuries that she incurred. She was alert, oriented ×3, and she had no known drug allergies. Next slide. So from the vital assessed, also the labs were basically unremarkable too. I didn't write them down, but there was nothing really remarkable. Slightly increased glucose. Localized assessment or focused assessment. I looked at her right lower extremity first, and it was immobilized with a knee immobilizer. Evidently, the one the doc put on her or the physical therapy put on her was insufficient, so she ordered one online, and was very happy with it. And I didn't remove it. I didn't feel comfortable to do that at that point. Also considering the restrictions with moving her around and stuff without an assistant there. The right patellar incision, she had about a 4-inch surgical wound. And I just looked at the wound. There was no redness, swelling, or discharge, and I could see that through the window in the immobilizer. There was an open area there. The immobilizer was held on with Velcro strips. There were a couple of butterfly tapes at the very bottom, at the most distal part of the wound that was healing fine. I checked her pedal and posterior tibial pulses, which were 2+ bilaterally. There was no pretibial or foot edema noted. Our capillary refill was very good too. It was less than 2 seconds bilaterally on her toes. Her plantar and dorsiflexion straight was 5/5 bilaterally. I also checked, so I did a full neuro on the lower extremity there, which we would do when, especially if a patient's in some sort of an immobilizer or had an injury to that area. Her sensation was present to sharp and soft touch. Then the left upper extremity I looked at just briefly. It healed without surgery. There was no sling currently on it either, and the strength was 5/5 with full ROM. Next slide. So then to focus on the physical therapy orders that were currently in place, these are the 2 types of hardware that she was using. There's the Velcro attached knee immobilizer that she was wearing on her right side, and they gave her what was called a hemi walker. And the hemi walker I had never seen. I didn't even know what it was, and she had to describe to me how she was using it. And it's very similar to what was explained earlier, that when she moved forward, she moved the hemi walker with the affected part to give it support. And it was better than a cane because it gave a little more support, and it wasn't as burdensome as a full walker. So I thought it was a really cool looking device. Physical therapy orders were to ambulate with the knee immobilizer and the hemi walker or a wheelchair, which she evidently wasn't even using. And she did that several times every day. And then actively assisted ROM of the left shoulder, and she did that several times a day also. Next slide. Medications too, I don't think they were overwhelming, and I wouldn't have really done any changes in them if I was in charge of the case. She was on sertraline for her MDD, or her mild depression, which is an SSRI, serotonin, selective serotonin reuptake inhibitor to increase her serotonin levels. She was on clonazepam, which is a benzo, and there are some questions now about benzos in older people possibly leading to Alzheimer's, but I'm not sure how far that's gone. I know there have been some studies about it, but she was on it, but she was on a very low dose, 0.5 POBID, and that was for her anxiety disorder. She was on aspirin, which again is being reconsidered now, evidently, whether it should be given or not in people, just in general. And this is, extended release, 81 milligrams, and that was for her coronary artery disease. She was on atorvastatin for her lipid disorder. Again, she had type 2 and she was on Plavix for her CAD, which was thinned her blood out. She was on Bethanacol for her urinary incontinence, which is typical, common at that age also. Colace again for constipation, very common in that age group. Glipizide was being used and was evidently controlling her diabetes very well, but there wasn't also an order for Humalog, 100 units sub-Q on a sliding scale if necessary. She was on the levothyroxine for her hypothyroidism. Metoprolol was just at that dose at 25 milligrams POBID was controlling her blood pressure very well, her hypertension. And lastly, the pantoprazole, which is used for her GERD, and a single dose, 40 milligrams usually given in the morning. Thank you.
Okay, so now we have a game. So some of you guys know how to play this game. We have played this game before. So it's basically like each round you spin the wheel and you play for that dollar points. And the purpose of this game is to just guess the guess the word. It's all those words that are used in the PowerPoint. But obviously in the beginning you won't be able to guess the word. So just guess an alphabet. And if it's right, I'll put in. If it's not, then I'll say it's incorrect. So let someone just say start and stop to spin the wheel. So first we're going to be spinning the wheel. Can someone say start?
Start.
I'm just going to... Okay, we'll be paying for 600 points. The category is functional status terminology that Sam was talking about. So it's one of the terminology for functional status. So guess a word.
Let's guess a word or a letter?
A letter, sorry, guess a letter.
S.
S, yes.
E.
Nope, no E.
A. A.
Yes.
Disability.
Yep, it is disability. And disability is an inability to perform an activity in a normal manner. And Sam used the example saying they're not being able to cut the food because of arthritis. So good job. Okay, so the next round, we're going to spin the wheel again. So someone say start and someone say stop.
Start.
I'm just going to stop.
Stop.
You lost a turn. So we're going to spin again. So 300 points. And this one is an example of a daily activity that Becky was talking about. So guess a letter.
A.
No A.
E.
Yes, there is E.
I.
Yes, there is I.
Toileting.
Yep, so toileting, eating, dressing, and moving were a few of the examples of daily activity living. Good job. So round 3, we're going to spin again. I'm just going to spin. I'm going going to say it's $300 points. We're going to go back to the round. And the category is one of the mobility aid that I was talking about. So guess a letter.
W.
Mm-hmm.
Wheelchair.
Yep, good job. Yeah, so wheelchair, canes, and walkers were a few of the examples of a mobility aids that was discussed in this chapter. Okay, perfect. Oh, sorry. So, okay, the last round, we're gonna spin the wheel. 800 points. This is a little hard one. It was something that Tommy was talking about, and it was promoting a mental function. So guess a letter.
R.
Oh, yeah.
A.
No A.
E.
E, yes.
Is it that reminiscence word?
Yep, good job, Kimmy. So reminiscence is a mental stimulating activity with a therapeutic aim, and it involves like improving memory, validates existence, and enhances the quality of life. Good job. Thanks for playing. And that ends our thing. So that's it.
All right, class. I am impressed with the game. Okay, you had my attention. Wow. I've not seen that game, so I love it when students teach me something. So do you mind if I use a game like that in my essentials class? Wouldn't that be good in essentials?
Yeah, sure.
You remember essentials, right? Wow, I've not seen that one before. So we always learn something new. Congratulations. That got me going. Yeah, great job. Does anybody have any questions for this group? Or any comments? I don't hear any. Well, I have a few, and I want to say that this presentation really brought out the most important things that I see in the chapter. For instance, the difference, what is sarcopenia, and what is the definition between a frailty and sarcopenia? Remember sarcomeres way back in physiology, you talked about the little sarcomeres in the muscle movement. So it's easy to remember that there's a problem with muscles when you're looking at sarcopenia and of course frailty. So be sure you do know those definitions of those two, specifically those words. Also, range of motion. I love the range of motion information, but I particularly enjoyed the warning signs if something was wrong, if you're doing range of motion and the patient is not happy with you. So those are important to remember, okay? Those are the warning signs, very good. And by the way, the page number on the terms for range of motion was on 462. So if you wanted to write that down, because that's just a review of everything that you have learned, in the past. Particularly, a lot of this was in Essentials of Nursing, and so I think it was excellent. The graphics were excellent. I do like the graphics that are in this particular textbook, and you utilize them into an excellent way as you were discussing the material. The how to get in and out of a walker, how to use the cane, what are the different types of canes. So that was awesome. I've already told you about the game. The other two definitions that is real important to remember is rehabilitation and restorative care. Those are two definitely different definitions, so be sure you are familiar with those definitions. It's important. Of course, your IADLs and the ADLs, they are different as well. Remember, the IADL is a little bit more higher level, you know, making phone calls, cooking, those types of things. So be sure you can distinguish between the two of those. So that was good. The positioning, it's always important to know how to position our patients. That's a basic fundamental information that you need to know. Let's see, the last thing that I was really impressed with was the use of the case study. It was well done. I felt like I was seeing this patient. I don't know how the rest of y'all felt, but that's what I saw. I'm looking at this patient. I want to be like her when I get old. Okay. Yeah. Yeah. Okay. But I really loved how the medications were discussed in pretty much detail. What was the medication for? And was it functioning for that patient? Was it working for that patient? Um, the question I have is on the comminuted patella. Did they replace the patella or did they just fix the patella? Because it looked pretty cracked.
They fixed it. They were able to repair it.
Wow.
The option was to remove it, but they were able to put it back together. And that's why I was amazed at her status after having, you know, pins and wires. If you look at what the surgery is like, it's very complex. And she even described it as, oh, they just sort of stapled it and taped it. You know, it was fun to listen to her about it. But if you look online and you look at pictures of what it looks like, it's pretty dramatic. And her recovery was just remarkable, that she's up and around without any pain. Because I think you mentioned too in lecture something about the knee is the highest level of a problem where there's pain. Had not, zero, and she didn't even have any meds prescribed for it, and that was for me amazing.
Yes, and it was only 5 weeks, and she actually went into the rehab 2 days after surgery.
Yes.
They don't waste any more time now. When you have surgery, they're going to boot you out of the hospital or the same day surgery, and off you go. So I think this does help us to understand a little bit more about the older person, the older adult. Not every older adult is frail, they might have a lot of issues, but they're not all senile. This woman sounded like she had so much resilience, and a great attitude. So thank you for that presentation. It was really excellent. You started off this class today where I even got goosebumps, and thank you for all of that, class. It was wonderful. All right. Good job. So it's 9:46. We're going to take a break, and then we're going to come back and we're going to talk a little bit more about pain and comfort. All right. So I'll see you back here at it's 9:46, 10 o'clock. Okay. Thanks again.
Thank you.
Mhm. All right. Hello, students. We are back. I think you can hear me. Can you all see my PowerPoints now? Hopefully you can see.
Yes.
Okay, thank you, thank you. So let me change my stuff on my desk. All right, let's do this. Okay. Well, on Tuesday, we actually watched this pain assessment video, and it is, as I mentioned earlier, it is videotaped or, recorded for you. But I wanted to go over some information that I wrote down that I think is important for you to remember from that video. For instance, according to the expert on that video, remember if a patient, particularly our older patients, if they have a pain of 7, it's very concerning. It needs to be addressed immediately. There needs to be some type of intervention. And I think that would be true for all of our patients, but specifically it was mentioned for our older adult patient. Sometimes depression, if an older adult has depression, they may not report their pain. And there is a possibility that some older adults will over-report their pain. So remember, it's not just one thing that we look at to determine patient's pain, even though we say it's whatever the patient says it is. We know what that means. So we have to keep those things in mind. And all patients, including our older adults, have to have routine pain assessments. Right? Excuse me. Another one, the first pain scale that we did talk about, or at least they talked about, was the pain AD, which is an assessment in advanced dementia. And it has 4 components to it. One is breathing. In other words, as you remember seeing the patient in the video, rapid breathing or holding their breath or having unusual changes in their breathing pattern could be a sign that they were having some pain. Obviously, the facial expressions, the scowling, the grimacing, looking fearful, maybe even saying bad words, swearing. Some of that could be possibly pain related. Of course, the body language, if they're fidgeting, if they're looking away from the person that they're talking to, if they become very, very tense. And I think you remember the one gentleman when they were trying to get him out of bed, he was yelling, and I mean, he was just making all kinds of noise. He was all stiff. And so that was some body language. Of course, how the patient vocalizes, what kind of sounds are they making? And of course, if they say something negatively about how they're feeling, we need to take that into consideration. And the 5th one is what they call consolability. And can you distract the patient while you're trying to do care for them? A couple more things that I wanted to mention that was really good in this video. That pain is not a normal part of aging, right? And many times our patients are not aware of what type of non-pharmacological medications, techniques are available to help reduce their pain. And so we as nurses, we just have to offer those to those patients and let them know. And what was very interesting is that 40 to 70% of the patients with dementia in nursing homes having pain. That's a huge percentage. So again, if you're working in a facility or you're having a patient come from a facility into your hospital or your clinic, keep in mind that there's a higher incidence of actually unreported pain in that population. Some of the reasons for that, sometimes these pain behaviors have been ignored or missed by the healthcare staff. Maybe the patient doesn't say anything about pain during the assessment by the nurse. Obviously, this pain that's not reported they may not understand how to really say this is the worst pain I've had. They may not understand that. So again, we have to be sure that when we're using any kind of scale, that we have to focus on it. The FLAC scale that you see up here it's a behavioral observation pain scale. It's not just a picture like the Legos that we just saw, but this is what we would have to be able to do, particularly on patients that are not able to communicate with us. The other thing, never ever say, well, that's how they always act, because sometimes it could very well be that the patient is having pain and perhaps no one on the staff has really done a more detailed pain assessment on our older patients. Okay. The contributions to pain, oh, I'm sorry, I thought I turned this. Contributions to pain, really depression, their appetite, if they don't have a very good appetite, if their physical functioning, such as the gentleman that we saw on that video, are they isolated? All of those can contribute to pain, but we do know that physically older patients have a higher tolerance for pain as well. So we have to keep that in mind when we're doing our assessment. Nurses should always be using some type of standardized tool assessment. The 0 to 10 may not be, numerical scale may not be the most appropriate for our older patients. So you can use the FLAC scale, which is the behavioral scale. That might be better tool. We do know that delirium can be caused by pain. And there's other indicators, for instance, if the patient doesn't want to move, again, if they start hitting the caregiver or pushing on them, or they're beginning to decline in physical function, or telling the caregiver to leave them alone, that could also be an indication of pain. For some of the care practices, which we would call, these are nursing actions or nursing interventions that I took away from that video, we want to be sure that we are moving slowly around our patient, that we keep them warm, we handle them very gently. If we need to give pain medications, we might want to do it at least an hour before we begin that AM care. And I know that in the facility, sometimes they start baths at 5 o'clock in the morning. We have to take that into consideration. I've seen that happen. Usually, it is recommended that standard orders for pain instead of PRN pain medicines, particularly for our older patients with dementia. All right. And of course, as always, we would pre-medication patients, of course, before any type of procedures. In the long-term care facilities, there are recreational therapists, and they know a lot about the non-pharmacological pain interventions, such as distraction, the hot and cold packs. Massage therapy is useful, and sometimes even actual acupuncture. And we need to be sure that we warn our patients before we move them. We don't just go in there and start moving them, because that's when they're definitely going to get loud or fight you. And of course, if the patient has dementia, that's a whole different way of dealing with those patients. So again, all of these care practices would be very useful, even taking care of those types of patients. So lots of information that came out of that video, and I thought it truly was a good one. All right, so just as a quick review of that video, and if you want to watch it again, you have access to it. All right. So here's a question. We have a patient who has late-stage dementia. Which behavior would best indicate that this patient is in pain? All right, let's take a look at that. Do you think it's his self-report of pain? The family says that he's in pain, that maybe he's agitated and he doesn't have a lot of socialization, or his wandering behavior. So which one do you think would be the best indicates he's in pain? Which one do you think it would be?
I would think C, because I know you mentioned earlier that sometimes like older patients can overstate their pain. So I don't know if a self-report would be as accurate.
I like that rationale. You're absolutely correct. C is definitely for a dementia patient. I'm sorry, I didn't color. So it is C, agitation and decreased socialization. Just because they wander, that doesn't necessarily mean they're having pain, because we do have a lot of dementia patients that will wander. Self-reporting of pain, as you were saying, may not be accurate. And so we need to look at other types of behaviors. And of course, a family can say their patient's in pain, but we can't just go by what a family member says. We actually have to do our own assessment on our patient. All right, good job on that one. All right. There is lots of complementary types of therapies that we can use for pain. And I'm not going to test you on these. I've already mentioned acupuncture, but there's a lot of different things that you have learned about complementary therapies that might be useful taking care of patients in pain or older patients. Obviously, I've mentioned massage, heat and cold, electrical stimulation, and all of those things. According to your textbook, there might be some dietary changes in our foods that might be useful, because all of these here could potentially cause a patient to have a little more pain, but also could actually cause them to gain weight. So these are just some basic dietary changes and what we would not want our patients to eat. And I think the egg yolk, that's really because of the cholesterol and those types of things. White sugar, sugar, high carbs, junk foods. It makes sense nutritionally not to use those. All right, so now we're going to start on a couple of slides on talking about medication. You're very familiar with lots of medication. The World Health Organization has basically put together a 3-tiered pain regimen for our older adult population. The first tier of pain, it is recommended that they use, the doctors would order a non-opioid analgesic such as acetaminophen. That would be better. It's a safe drug, it's easily available, it's over the counter, and it comes in a number of different sizes, like 325 to 500 milligrams is over the counter. One thing about acetaminophen, it really helps if the patient also has, besides acetaminophen, maybe with another opioid. It can actually enhance the pain relief, so sometimes they will recommend that. And it is best for nociceptive pain, which is, say, somatic pain, where there's a lot of inflammation. That's what acetaminophen is good for, as well as visceral pain, where a nerve, say, is being stretched over some type of organ. It does not directly address your neuropathic or your peripherally and centrally located pain receptors. But for the somatic and the visceral, it seems to be good. However, keep in mind that acetaminophen will not help to reduce inflammation. It's really used as an antipyretic. And it really helps to reduce some of those painful signals that the patient has in the body. And we don't want to administer both acetaminophen and an NSAID together, because what happens is going to exaggerate the toxic effects of both of those medications. So again, you don't want to mix those two together if you could possibly help it. And there's much more information about that. So let's look at it just a little bit more. I just mentioned about the acetaminophen. Now the next drug that likes to be used is your NSAIDs, and of course your ibuprofen is the most common. This one works best on nociceptive pain. Okay, the somatic and visceral pain. So this really works best. However, we have to remember the side effects of the NSAIDs before the doctor will actually request that to be given to a patient, because with NSAIDs, long-term use can cause GI bleed. It does block some transmission of pain receptors, and so it's a good drug to use, and there's lots of different examples of that, we know about ibuprofen, this naproxen, also known as naproxen, you probably recognize that. Ketorolac or Toradol is a good NSAID for our patients. Just as a reminder that the ibuprofen is particularly effective for bone pain and dental pain. So bone pain and dental pain seems to respond to this particular drug much better than some of these others. And there's others, indomethacin like Indocin, that's a good one as well. All right, piroxicam. Piroxicam is also an NSAID that's known as Feldene, F-E-L-D-E-N-E, piroxicam. Just a couple of examples for you. With the NSAIDs, just remember that 3 things happen with the NSAIDs. First of all, it inhibits the platelet aggregation. That's one reason they recommend that if a patient's going to surgery, that they're not to be taking an NSAID at least for several days, but particularly before elective surgery, because it would inhibit that clotting process. And we also want to be watching for any signs of potential bleeding, like easily bruising, any type of GI bleed as well. NSAIDs do help to promote renal insufficiency because it excreted renally, and so it's a challenge for anybody who has renal problems. All right, and it blocks the prostaglandins. In other words, it reduces the fever, pain, and swelling that the prostaglandins cause, particularly when they start working in the body. So, but sometimes we have to kind of remember those things. So just 3 things as a class NSAIDs are. Again, I've already mentioned not to put both NSAIDs and acetaminophen together. They do use COX-2 inhibitors such as Celebrex. All right, sometimes they will use that, but it was taken off the market not long ago. I don't know if you remember. The Celebrex, the COX-2 inhibitor, was removed from the market simply because it was increasing cardiovascular problems in our population. So we probably won't be seeing that very often. Misoprostol, I'm going to spell it for you, M-I-S-O-P-R-O-S-T-E-L. It's known as Cytotec. It's rather expensive. It does have high side effects of diarrhea, but it can also help to minimize any kind of GI toxicity. So it's a good medication for that. Opioids, let's talk about opioids. There's 2 types of potencies. One is low and one is high potency in relationship to our older adults. Remember that opioids can minimize pain perception. They're centrally acting. They dull the perception of pain, but they don't really reduce that painful stimuli. They just dull the perception of the patient about that pain. So a couple of samples of a low potency. This is step 2 of the analgesic ladder, is Darvocet. Darvocet is a propoxyphene with acetaminophen. However, it's really not recommended for chronic pain because of the side effects. So that's Darvocet. A second one is Tramadol, which is known as Ultram. It's fairly new. It's similar to opioids, but it's technically not an opioid, but it works like one. And it doesn't have really any type of abuse potential, so that's why it's a pretty good one. It's fairly new, and it is centrally acting as well. The highest potency in the analgesic ladder for our older patients is hydrocodone with Tylenol or acetaminophen. We call that Vicodin, Lortab, you may have heard of those terms. Oxycodone with acetaminophen is known as Percocet. So that's very high potency, pretty powerful, right? There are some codeine preparations, of course, that has caffeine in it, codeine, and maybe aspirin or acetaminophen, but those are extremely high potency. So we use those with caution for our older patients. Fentanyl, they've kind of taken away fentanyl. We do still see patients with it. It's a transdermal patch, if you remember. It's not by mouth, so it's really not the preferred medication for our older adults. Dilaudid, again, it has to be taken every 4 hours, and so we don't like to use it too often because the patient sometimes forgets when to take it. So I think the takeaway from this is to remember that we want to start with the lowest dose. You want to go low, start slow, and go low. So let's try the acetaminophen first. Then if we need acetaminophen and an NSAID, make sure we understand what's going on with the patient, or maybe just an NSAID. But again, always remembering the side effects of an NSAID with the patient. And go to those opioids only if necessary. And we do have patients on morphine drips in hospice. So sometimes we just have to weigh the risk and benefits, and the doctor will do that. They'll look at okay, what's the risk, what's the benefits, particularly in someone who is in terminal illness. All right. So just a little bit about some medications and pain. Propoxyphene, of course, is Darvocet. We know Tylenol. Oxycodone is Percocet, and of course, fentanyl is known as Duragesic. So which of these meds is contraindicated in the older adult related to potential side effects? Which one of these really we don't want to give to our older adults? The answer is, go ahead. Yes. Perfect. You said Darvocet? Yeah, absolutely. Propoxyphene, and the reason for that is contraindicated. It doesn't really add a lot more benefits than some of the other meds. Of course, it does have a potential to affect the central nervous system a little more than we want for our older patients, and it can cause cardiac problems or cardiac toxicities. So again, we don't really want to use Darvocet if we don't have to. All right. So now we have a thinking exercise. I'm going to use some critical thinking here. Are y'all ready for this? All right, let's have somebody read this clinical exercise and keep it in mind as we go on to the next slide. This is our scenario, and then you're going to have a nurse's note on the next slide. Who'd like to read this? Okay, I'm waiting. I have to call on somebody.
I'll read it.
Thank you. Thank you so much. All right, go ahead and read this. This is going to be your scenario, your patient.
Okay. A 62-year-old female client with a history of hypertension, gastroesophageal reflux, osteopenia, and osteoarthritis has been managed for cervical and lumbar back pain for the past 20 years with ibuprofen 800 milligrams orally once daily and hydrocodone, acetaminophen 10-325, 1 tablet every 6 hours is needed. She is admitted to the hospital today for possible lower GI bleeding and scheduled for a colonoscopy tomorrow morning.
Okay, what does the 10-325 mean?
10 milligrams of hydrocodone, 325 of acetaminophen.
Perfect. Yes. So this patient has been on that for a while, and now she's going for lower GI bleed and scheduled for the colonoscopy tomorrow morning. So let's take a look at the nurse's notes that goes along with this patient. All right. All right. Who would like to read the nurse's notes?
I can read it.
Okay.
I didn't know there was.
Okay.
11/9/20 at 19:15. Given hydrocodone acetaminophen as prescribed an hour ago, but reports 7 out of 10 lower back pain on a 0 to 10 pain intensity scale. pulse is 98, blood pressure 164/88, which have increased since admission. No obvious blood in the stool, but sent to lab for occult blood testing. Waiting for lab results for CBC and BMP.
Okay. All right. So this is the nurse's notes that I wrote. So what I want you to do with this one, I want you to highlight the findings in this note that indicate that our patient's drug therapy is not effective. If you had a highlighter, what would you highlight to indicate that the drug therapy that we've given to the patient is not effective?
Seven out of 10 after administration.
Okay. Anything else?
IBP.
Did you say, what did you say?
The BP is still kind of high.
Yeah. Okay. Anything else? Any other thing that might indicate? I'm not saying there is, I'm just asking.
The pulse is kind of high, but I don't know what the regular pulse is for.
Okay. All right. So let's take a look at the answer. Okay. So basically, you were absolutely correct. What's happening here is that the back pain is still pretty high on a 0 to 10 scale, of course. There's that 7 again. If it's a 7, we definitely have to do something. They just had the Darvocet here. Pulse, even though it's at the upper end of the range for a patient, that's still a little bit high. We would be concerned about that for our patient, even if we don't know any other information, the past for the patient. And of course, we're looking at the blood pressure. So very good. You did really well with that. And by the way, in the future of NCLEX, this is the kind of question that a student will get, or a graduate nurse might get. This is just one of many. In April of 2023, there's going to be new things to do. And luckily, y'all are going to be all graduated and be working by then, right? But this is the kind of some of the questions that you're actually going to be seeing in April of 2023 when they add these to the NCLEX. So I just wanted to just kind of show you because it helps to really develop some more of that critical thinking. And I have a couple more scattered throughout here, so we'll look at those. Any questions on why we answered it the way we did? All right, good job. Comforting is something that we just have to do. Remember, we want to give our patient as much attention as we can, regardless of the length of the interaction. And I think that's important. We need to give them undivided attention because our patients need to be comforted. Even when they're in pain, we want to comfort them so that will help them to relax. We also want to be able to listen to them carefully, hearing everything, and let them do a lot of talking if necessary. And we want to explain and clarify anything that they have questions about. And of course, think about the power of presence. We've talked about that several times over the last few quarters. That means your presence in the patient's room, standing beside the bed or sitting beside the bed and talking to the patient, your presence can really bring out a lot of comforting for our patients. And of course, we're going to be using evidence-based practices as we are taking care of our patients who are having pain. And always remember to respect their cultural needs, their understandings, and those types of things. So comfort is definitely something that we as nurses can do, holding their hands, whatever it might be. All right, so now we have another thinking exercise. All right, so let's take a look at this one. Who'd like to read this one?
I'll read.
Okay.
A 66-year-old male client was diagnosed with metastatic bone cancer last year. and has been on a variety of opioid drugs to manage his severe pain. He is currently a resident in a long-term care setting under hospice care. Recently, his opioid analgesic was changed to fentanyl 50 micrograms per hour via transdermal system, which seems to be managing his cancer pain. This morning, he was transferred to the emergency department for evaluation after sustaining a fall. His admission findings include the following.
Okay, so let's look at his assessment findings. Maggie, would you read these?
Assessment finding, temperatures is 97.6 degree. Pulse is 79 beats per minute and regular. Blood pressure is 167 over 72 millimercury. O2 saturation is 95% on room air. Pain level is 8 out of 10. Left groin and knee, no shortening or rotation. Leg in alignment. Neuro is alert and oriented, time 3. Respiration is breath sounds clear in all lungs field. CV is post 2+, except for both pedal post at 1+. Comments grimacing when moved and grabbing his left hip. States that pain behind left knee is worse than groin pain.
Okay, so let's take a look and see if anything that's unusual about this patient. What do you recommend that we might want to be looking at? And we're in relation to pain. So if you're clustering your data from this assessment findings, what data would you include in potentially for pain?
You're referring
blood pressure.
To left groin?
Okay, I heard blood pressure. What else? Did I hear pain? Somebody said something about a groin. Okay, so pain level of 8, a little bit high blood pressure. What else?
The pedal pulse, 1+.
Okay, do you think that would be related to pain?
Grimacing.
Okay, it's possible that they might be having pain in their feet. That's true. Grimacing, definitely. Grabbing his left hip and actually telling us as a nurse that their pain is really, really bad. So you're going to choose the most likely options. I've given you the options in a list here, and you're going to fill in the blanks. So the nurse anticipates that the primary healthcare provider will prescribe something because the client has something. However, he will continue to receive his fentanyl patches to help control his blank. So let's fill in the blanks.
All right, I think the first one is an analgesic.
Okay.
Because the client has is it neuro?
Like pain, maybe?
Pain.
Okay. What does the class say? Going to have an analgesic because the client has what?
Acute pain. Acute pain.
Okay. All right. And So he will continue to receive his fentanyl patches to help control his what?
His chronic
Cancer.
Cancer pain. Excellent. I give you the answers and the rationale. And notice that he's receiving fentanyl for his chronic cancer pain. That is true. However, he's got a new injury. And he's talking about his new injury with the pain. His blood pressure and pulse, as you indicated, are increased. You did a good job on the findings. And it's common in our patients who have acute pain. So he'll need an analgesic to manage his acute pain. How'd y'all do? Pretty good? Sounds like you were thinking through it. Good job. Right. This is another example of what is going to happen in 2023. You won't have these, so not to worry. All right. All right, so this is a really good way of doing some critical thinking and taking care of patients in the clinical setting. All right. Any questions about comfort and pain and all of those things, and we will move on to our next chapter. All right, no questions? All right. All right. So hang on a minute. I'm going to switch this out to our next one. We can talk about reproductive and then cancer. That's fine. Y'all doing good. Getting your minds flowing here with all this information that you have. So our reproductive system is chapter 22. We won't talk a whole lot of information, but there are some things you need to be aware of for the older adult patient. As we have already discussed earlier in this particular quarter, is that older adults sometimes don't like to talk about anything to do with reproduction or sexual activities and those types of things. So the thing is that we as healthcare providers, we have to be able to talk with our patients and try to get as much information as we can to see if there is any kind of problem, either related to their physical concerns when we do, like bleeding from the vagina or pain in the lower abdomen, or also to find out about their sexual activity, because we want to make sure that the patient is well aware of STIs, sexually transmitted infections, so they know what, how to protect themselves. Because remember, older adults actually perform sexual activities. So here is the effects of aging on the female reproductive system. The vulva atrophies, the labia begins to flatten out, and then subcutaneous fat and hair begins to disappear in the lower areas of the body around the perineal area. So important to know the effects of aging on the reproductive. So please be sure you remember these things. The vulva gets kind of tiny, it atrophies. The labia on both sides. Remember when you're doing your pericare prior to inserting a bladder catheter, those are the labias that you're holding apart. Those begin to flatten out a little bit. They lose some of that subcutaneous fat in the hair. The epithelium in the vagina becomes thinner. And of course, a lot of times there's a little bit more discomfort and pain during sexual intercourse. And then everything else that's part of the reproductive system tends to atrophy. Again, we do have some reduction in the adipose tissue, as we mentioned, in collagen. The canal, the vaginal canal, will shorten a little bit. And as we mentioned already, there's going to be less lubrication. So sometimes that we can suggest using some type of non-oil lubricant, all right, because of the pain. And the vaginal pH becomes more alkaline because there is a change in the estrogen within the body. The thing to kind of think about is that these are normal changes in our patient. However, satisfying sexual experiences are possible, but because of these issues, maybe a little bit more painful because the vaginal canal has shortened. It's a little bit more painful, and so maybe they have less interest in sex. Breast tissue becomes less firm. There's more sagging going on, and sometimes even the nipples retract as a patient gets older. So some of the abnormal changes in the female reproductive system would be cancer, particularly vulvar, cervical, and uterine cancers. That's in the female. So in the male, the seminal vessels develop, of course, thinner epithelium. There's a reduction in sperm count. The muscle tissue is replaced, of course, with connective tissue. And so they cannot retain fluids. It doesn't hold as much fluids as it needs to for carrying the sperm. And there's a lot of fibrosis and thickening and narrowing of the lumens as the male begins to age. There is a problem with the testicles. They tend to atrophy, and testosterone, remember, diminishes slightly, but generally the testosterone level on a male, older male, remains the same. That's important because sometimes we think that, oh, the hormones are lower in females, it's going to be lower in males. That's not true. So the testosterone level does remain the same as they get older. Erections are a little bit more difficult for the older gentlemen. And sometimes they're not able to maintain that erection, of course, causing frustration for both partners. The prostate gland tends to get large, and because the prostate has a lot of fibrotic tissue, which then interferes with, of course, their urinary system. So two abnormal changes that we do see, these are the normal changes, but the two abnormal ones is erectile dysfunction. That is considered an abnormal change. And of course, prostate cancer risk increases. All right. So those are the effects of aging and some of the things that are actually abnormal. So let's talk about health promotion for both the male and female. Be sure to teach your older patients how to do a self-breast examination. For men, we want to teach them how to do that testicular exam. Talking about sexual health or their sexual activity, we kind of talked a little bit about that using the Plicit scale earlier on this quarter, but we have to have a really good understanding and rapport with our patient before we start asking questions that are extremely sensitive. So we need to be very private when we start asking them about their sexual activity. We do have to really ask permission before we get into those types of questions. Because we want to make sure that they understand that sexual activity is normal for older adults, but they need to be comfortable with us. So we're going to ask them, are they sexually active? Some questions that you might ask for men would be like, have you had any change in sexual function, especially your erections? And we can tell them that older men really have a slower arousal mechanism, and the erection can be slow to occur. Takes a little bit of time. And you can just ask them, are any of these happening to you? We want to ask them that. It's okay to ask them. So basically that kind of discussion with them really helps the patient to be able to verbalize and discuss their experiences without feeling embarrassed or afraid to say anything. We could also ask them about their testicles. Has there been any change? Because men know their testicles just like women know their breast. So you could ask them, do you examine your testicles on a regular basis? And if not, then of course you could teach them how to do regular testicle exams on themselves. For women specifically, we could ask them such things as, have you noticed any changes in sexual function over the past year or so? It could simply be because of the estrogen droppage. Are they reporting any type of vaginal dryness or pain when they're penetrated in the vaginal canal? And if so, we want to see if there's some things that we can teach them and help them. And they also are going to ask questions such as, do you have the ability to have an orgasm? Because remember, the vulva will actually atrophy, and so sometimes that does affect the ability to have an orgasm. We need to be very calm, matter of fact with these patients when we're talking to them, and then give the patient time to think about the answers to the questions before we push them too hard. So let's look at some actual conditions related to the female. The infections of the vulva, the most common symptom is itching. That is the most common symptom, right? Sometimes sitz baths and saline compresses or steroid creams could be useful to help these infections, all right? Particularly if the patient is having a problem with this. And so sometimes we can offer that to them, all right? Topical steroid creams is also very useful for dealing with vulvitis. What about vaginitis? Another condition for the female. Remember, because the vaginal canal shortens, there's a reduction in collagen inside and adipose tissue. The elasticity of the vaginal canal is much less. There's very little vaginal secretions, or at least a little bit less than they normally would have to help with the sexual act. And also because the alkaline vaginal pH, that's one of the reasons we see vaginitis occurring in our postmenopausal women. So some of the signs and symptoms for vaginitis, of course, would be soreness, pruritus, itching, a reddened vagina, burning, foul-smelling vaginal discharge. It could be clear, it could be brown, it could be white, different colors. The problem is that untreated vaginitis can cause bleeding and adhesions to form, which makes it even worse for them. Sometimes the healthcare provider will order some local estrogens, in other words, estrogens that can be applied to the vaginal area. Sometimes boric acid and other types of douches can be ordered by the healthcare provider. But we need to teach our patients about how to give a douche, making sure the fluid is not too hot, check that temperature. If they're sexually active, they need to avoid the douches. Don't use perfume soaps, you know, the typical things, wear the cotton underwear, no sprays, all right? Keep everything clean and definitely use a lot of lubricant during intercourse. All right. So when we do have a patient and they come to the clinic and they have recurrent vaginitis, they have a history of recurrent vaginitis, when we teach them, we want to teach them about douching with a hypertonic saline occasionally. That helps with some of this vaginitis symptoms. All right. Another problem for women is cancer of the vagina. It is rare. It usually comes from metastasis from some other part of the body. And of course, chronic irritation in the vagina can actually increase the potential for vaginal cancer. And they really should be having Pap tests frequently to make sure they're okay. After the age of 68 or so, they don't do a whole lot of Pap tests, but because it is a rare form of cancer, they don't do a whole lot of treatments. But if they have to treat this type of cancer, it would be more like radiation, chemotherapy, and maybe even surgery. Cervical changes, of course, we do know occur. The cervix, of course, becomes smaller. The epithelium will atrophy. Everything seems to atrophy in the older person. There are endocervical glands. Remember, those are secretions that help to lubricate. Well, those glands can seal, and if they're not able to release their fluid, they'll have what they call Nabothian cyst, which can be very painful and hurt, and they like little tenders, so they have to usually be lanced and drained. We recommend regular checks for our older patients until they reach a certain age. So there is cancer of the cervix that we think about. It is prevalent in, say, about 49 years of age. Hispanic, blacks, and whites have similar incidences for the cancer of the cervix. Signs would be, say, vaginal bleeding or leukorrhea, losing a lot of white blood cells. Generally, there is no pain. It's a cancer, so there's usually no pain. There could be some urinary incontinence or retention, maybe even some fecal incontinence, some uremia. Generally, over 65 with a negative Pap test in the last 10 years, there's no need for cervical cancer screening. So that's what I was saying earlier. Radium and surgery, you know, that can help with someone who has cancer of the cervix. So it's not as, we see it, but over 65, it's not something that is as a concern, particularly if there's a Pap test been done within 10 years. Now, cancer of the endometrium is not uncommon. This is one that's really a bad one. It is not uncommon. There is some post-menopausal bleeding, and that should be suspicious. If somebody has gone through menopause, they should not be bleeding. If they start having bleeding after that time frame, then it could be potentially a sign of endometrial cancer. Not all cases of endometrial cancer can be diagnosed by that Pap test. So a lot of times they will dilate and they'll go in and cut to confirm any type of biopsy. So they'll take a piece of the endometrium and, you know, send it to the lab. If it's called in time, early treatment can really help to reduce that metastasis to the vagina and cervix. So cancer of the endometrium, unfortunately, sometimes is not found early enough. And of course, you know, it can definitely metastasize. All right. There are endometrial polyps that can form in the older person, and they can bleed. And those little polyps could be a kind of a possible indication that the patient has early cancer. So they worry about those polyps if they see them or if they find them. All right, so cancer of the endometrium. Cancer of the ovaries. It looks like every body part of a female gets cancer. Yeah. Cancer of the ovaries, of course. Early symptoms are very nonspecific, maybe a little bit of GI distress, all right, but very nonspecific. Unfortunately, it creates, because of that, by the time they discover that the patient has cancer of the ovaries, there's multiple masses, there's a lot of bleeding, ascites has begun, you know, they start developing fluid, and it is the leading cause of death from gynecological malignancies, is cancer of the ovaries. And really the only way to treat that is surgery and radiation. Here's another very interesting problem among older women. It's called perineal herniation. Now, what happens is that sometimes the bladder will prolapse, the bladder will drop down, and you can actually feel the bladder through the wall of the vagina. We call that a cystocele. A rectocele is when the rectal wall, or the front of the rectum, actually prolapses. And of course, we also see a prolapsed uterus from time to time. But this is a very common problem in older women, and we see it more commonly in women who've had more than one baby. So keep that in mind. Some of the early signs and symptoms for this, just like lower back pain, their pelvic feels really heavy. They feel like there's a pulling sensation going on in their body, in their lower body. Sometimes there's urinary and fecal incontinence associated with this, maybe even some retention and some constipation. Because think about it, if your bladder, if the female's bladder is dropping down and hitting that vaginal wall, it's going to cause some issues. There's going to be problems with sexual activity as well, or intercourse, a lot of difficulty. We will be able to feel a mass inside the vagina, which could indicate that there's something pressing against that, whether it's the rectum, whether it's the bladder, or the uterus falling down, okay? And really the only choice treatment for this type of herniation is surgical repair, okay? If you have let's say an example, which if you have a woman who's had 5 children, right? And they ask you, what effect will all of these kids have on my urination? You can actually tell them they can be easily a potential for developing perineal herniation or prolapse of the pelvic organs. So the more children they have can actually interfere with their bladder, their rectum as well, and their uterus. So that's a common problem. Painful intercourse is known as dyspareunia, and I think it's on this next slide. Okay. Very, very painful intercourse due to hormonal changes. It's not a normal consequence of aging, though, so please remember that. It comes with women who have not had too many babies. Lots of things can contribute to that, and basically, because it's painful, they need to find out what is the problem and see if there's ways that we can help them achieve that satisfying sexual life that they are desiring. So, dyspareunia. The second leading cause of death in women is cancer of the breast. It's the second leading cause of cancer deaths. The older we get, the risk, of course, increases with age. Remember, there's a decrease in estrogen. Estrogen tends to help females kind of fight off breast cancer. So we know that women very early can actually have breast cancer. However, estrogen is something that they do. Now, sometimes they will replace estrogen as the patient gets older or the woman gets older, but there are risks with taking estrogen. Cancer is one of them. Okay. Annual mammograms for women recommended starting at age 40 and then at age 75 every 2 to 3 years. Every 2 to 3 years by the time the patient reaches 75. So if a woman's between 40 and 75, they should be usually getting an annual mammogram. Men can also develop cancer of the breast. It's very virulent, and they don't do as well as women do with that kind of cancer. So let's look at a few problems with our men, just a few slides, and then we're going to take our break here, okay? Erectile function obviously it really affects most of our men over the age of 70. Lots of causes, of course. It could be from diabetes, or alcoholism, or problems with lipids, hypertension, even multiple sclerosis, renal failure, and spinal cord injuries. All of those things can affect the ability to have an erection. Drugs can also affect a male's ability to have an erection, such as the anticholinergics, the antidepressants, the antihypertensions, digoxin, and sedatives. So there's many things that can affect our patients. Many drugs that they take routinely because they're older will affect that. There is some treatment. Viagra, you've heard of that, I'm sure. Sildenafil, remember the FIL at the end? Sildenafil, Viagra, Levitra, we see these advertised on TV, Vardenafil, and Cialis, which is tadalafil. So those, be sure you know the 3 treatments. And sometimes they can actually put implants into males who have serious erectile dysfunction. Most men, unfortunately, has the hyperplasia of the prostate. And we talked about that because the prostate becomes fibrotic and it swells up, all right? It presses on the urethra. So the patient will have a hesitancy to void. The force of their urine stream is going to be decreased. They'll go frequently. They dribble. Lots of nocturia. They'll be getting up many times during the night. They have very little control, or I would say poor control, of their urine. They can also develop what we call overflow incontinence because there's so much urine in the bladder, it just kind of overflows a little bit. And it actually can cause bleeding. So benign prostatic hyperplasia can do all of these things. Remember, the bladder wall in both males and females lose their elasticity, becomes thinner. Urinary retention is a great risk. And of course, when you have urinary retention, remember, you're going to have an increase in risk of infections. There's a really nice nursing care plan in your textbook on page 325 and 326. It's about an older adult recovering from prostate surgery. I think it's really, really good. So take a look at that. For men, cancer of the prostate increases as well with age, right? The prostate-specific antigen, you may have studied this, the PSA, it really grows as the patients will advance in age. But a PSA above 4 to 10 nanograms per mil is kind of suspicious, and the doctor will order further evaluation for that. Of course, the digital rectal exam by the healthcare provider will also be able to let them know if there's some type of increased swelling in the prostate. And there's all kinds of options for this. Surgical interventions, radiation, hormone treatments, okay. But the thing for nurses, some of our interventions for this, we need to focus on the patient's anxiety and their fearfulness, because cancer of the prostate is kind of scary. They may not understand about the surgical procedure, so we be sure we do lots of teaching for them. There might be some pain at that surgical site, so we teach them about all those things. After surgery, there might be a little bit problem with urinating because of the swelling due to the trauma that occurs. So we have to let them know that, all right? And sometimes they can become incontinent after surgery. So we want to be sure that we look also and talk to them about bowel function because constipation, straining, really can be detrimental on a male who has had a prostate cancer and the prostate is removed. So keep in mind that that has to be looked at. So for some who has prostatic hypertrophy, generally they should be examined about every 6 months to make sure that a malignancy has not developed, because we know that with increased prostate size, there is an increased risk of cancer. So about every 6 months, they need to be getting checked for cancer of the prostate. Tumors, cancer of the penis is rare. Okay, however, I have seen a patient with cancer of the penis. I don't know if I mentioned it way back when, but I'll mention it to you again. The gentleman was probably in his 80s, and he came into the hospital because he had had a suprapubic catheter inserted. He had been using, he'd had it for, gosh, a year or two. It's been a while. He was an older gentleman. But when I went to clean him, there was no penis there. They had taken his penis off. And he said that what happened, he started getting these lesions. They told him that he had penile lesions or cancers. They had to cut his penis off because he didn't do anything about it. And he waited and waited till so long. Then finally they just took his penis off because there was nothing else they could do. So that's why he wound up with a suprapubic catheter. Now, he did have a bladder infection. That's why he came in. He did fine with the treatment, and he went home, so no big problem with that. Cancer of the penis looks like, usually it's painless, because that's one reason the gentleman said he didn't do anything, because it didn't hurt. Sometimes they look like little warts, and they're usually around the prepuce or the glands at the end of the penis. And sometimes they are misdiagnosed. So the only really way to determine, the healthcare provider to determine if it is cancer, is to do a biopsy. The treatment is irradiation or local excision, but his was so bad that they had to remove his entire penis. Basically, it rotted off. All right, but he survived it. Testicular cancer is uncommon, but if a patient gets it, if a male gets it, it's usually very malignant. There can be testicular or breast enlargement with a male who has testicular cancer. And the testes is actually going to be painful, even with this cancer. So again, just a few things here on the male.
So, Professor Stevenson?
Yes.
I have a question. The cancer of the penis, is it often misdiagnosed as an STI?
Yes.
Okay, and so that's why they have to do the biopsy?
Right, right. You know genital warts, right?
Yeah, warts,
Yeah,
but then also, like, if lesions, you know, it could look like herpes or something.
Perfect. You're right, Melissa. Yes. Yeah, sometimes it's misdiagnosed. And so the only really way to find out if it's actually cancer is to do a biopsy. But the gentleman that I had taken care of, he was obviously full of lesions. And, you know, it's kind of like, whoa, this doesn't look right. So they biopsied and found out he had cancer. But it's rare, but it happens. All right. And one of the things is that he didn't go to the doctor. He said he thought it was okay. He just thought he had some sores down there. So he didn't do anything about it. But it was too late when they did catch it with him. But that's a good point you make, that it is many times it's misdiagnosed because it looks like herpes lesions or even genital warts.
Well, yeah, and warts you can't do anything about. So if you just leave them and they continue to grow.
Yeah, warts, they can burn those warts off.
Oh, yeah. But
there's some medication. I tell you what, I was, as a student, I'll never, if you go through some kind of traumatizing thing as a student, you never forget, right? So I remember I was working in like a health department, and I was assigned to take care of the females. I was in there, observing, and there was this girl, and I was so young, I had never seen genital warts before. So when I went in there with the nurse, the RN, I saw this lady, this young girl, had these huge cauliflower-looking growths in her vagina. I'll never forget that. I was traumatized. And so they were actually at that point putting painting down with what we call gentamayan blue, or I think it's genta something blue. It's like a methylene blue, and it's some type of chemical that can actually dry them up and get rid of them. But yeah, some things we just don't forget, even as a student in all these years. But I do remember that part, yeah. But they can remove the genital warts, or they can treat them, but it's not something that, yeah, that patients should have. But the cancer itself can also look like wart-like growths, so sometimes they think it's the genital warts. Yeah, good point. All right, just another one more slide, and we're going to be done, and we're going to take that break. All right. So tumors of the scrotum are usually benign. They can show up because, say, a hydrocele, maybe the patient had a hydrocele or spermatocele or even a hernia. They're usually treatable. So the healthcare provider will just treat the underlying cause of the tumor of the scrotum, right? And of course, all of that will affect a male's self-image and their ability to have sexual activity. So again, the messes in the scrotum are usually benign. All right. So any questions do you have about this? All right. I think it's time for a break. It's 11:13. Come back at 11:30. I need to give y'all a couple extra minutes. Y'all been so patient. When we come back, we're going to talk about chapter 28, which is cancer. Again, just a quick review as the many things that you may already know, and even a little bit of review of what we just talked about in the reproductive system. So come back at 11:30, and I'll see you then.
Thank you.